Okay, good morning, everybody. Thank you for joining us. As usual, those of you who join us every week know that we usually give it just a brief minute so everybody can join us in the attendee room. Again, thank you for being with us this morning. Before we start, we'll of course have a couple updates this week as we generally do. Just want to acknowledge and just make sure everybody is doing well and being safe out there. It's been quite a year with a number of stressors. Of course, the most recent one are the wildfires here in the Bay Area. We hope everybody is being safe and taking good care of themselves and each other. We're going to send out just a brief reminder that the WellMD folks do host a website with a number of resources, both designed to support people during the COVID time and of course also during this time as well. So please take a look at that and make sure you can use those resources if needed. Hopefully, again, you're doing okay. We also thought that this would be a good time to send out another one of our routine surveys we've done in the past. We haven't done it for about a month now. And we just want to make sure from a communications perspective that we are making sure that we are getting your input and hearing your voice. And we want to make sure that everybody in the department and everybody who comes to these grand rounds has a voice. It's really, really important to us. So please, if you'd like, take a look at that survey and fill it out. The questions are optional. And it's just an opportunity for us to make sure we're doing everything we can to communicate to you. We think of these grand rounds as more than just sharing information. We're trying to address anxieties, fears, and make sure everybody has that voice and power in our community. So with that being said, we'll send that. So thanks, Helena, for sending out the links. We'll send that out again later in the presentation, as we know a number of people will join in the next 10 minutes or so as well. And please do feel free to reach out to us and the communications team with any feedback you have to make sure that we're doing we're communicating the right way. With that being said, we'll turn it over to Dr. Ahuja again, as every week she provides us an update on COVID in the clinical status. Dr. Ahuja, we'll turn it over to you.
Thank you, and good morning, everyone. As I share my screen, I just wanted to acknowledge, I'm pleased to say today we have some of the lowest COVID numbers we've seen in some time. And you can see this on the trajectory. You know, the overall numbers have been decreasing with both the AAU or ward numbers decreasing as well as the ICU. Today we have 17 COVID patients in-house with 6 in the ICU. The total number from March 1st to August 23rd for COVID inpatients has been 368. Our ICU percentage has just crept over 22%, so just over 20%, which is where we were hovering. And the death rate stays close to 5%. We have just slightly more females than males as we have had. And you know, the age distribution frequently toggles between these two age groups. And so this is sort of where we've landed, and we'll continue to keep an eye on all of these data points. Just looking at the breakdown of the deaths, you know, these are all deaths. We've had 21 total at SHC, and this is the age breakdown here. So you can see the, you know, males slightly more than females. The N overall is low, fortunately. And then finally, just a quick snapshot of the pediatric inpatient numbers. There have been 38 admitted COVID patients to the Children's Hospital, but of them, the majority have been asymptomatic and found to be COVID positive on admission, but admitted for other reasons. And there have only been 4 patients in the moderate to severe category. So those numbers will continue to look at the trends, particularly over the winter season. And then finally, if we do see any wildfire related admissions, we'll be sure to share any trends with you. Right now, there's not enough data to see, but we'll keep an eye on that given the current situation. Thank you, and I'll turn it back over to you. This is my data team, and acknowledging Dr. Matthew from Pediatrics.
Great, thank you, Dr. Ahuja. I appreciate that. It's great news. We'll turn over next to Dr. Marie Hollenhorst. Dr. Hollenhorst, thank you for joining us again in Grand Rounds. And she's joins us from the Division of Hepatology and is going to give us an update with convalescent plasma, which we thought would be a good time to do now with all the stuff that's been going on in the news. So thank you for joining us.
Well, thanks so much for the invitation to give a brief update on convalescent plasma. So as this audience is probably pretty well familiar with, convalescent plasma is plasma which is collected from an individual who's recovered from COVID-19 infection. And we hope that this plasma contains anti-SARS-CoV-2 antibodies that can be helpful when transfused to an individual with an active infection in mitigating the severity of their disease course. So the key question for discussion this week is COVID convalescent plasma efficacious? And the focus of the data has been on data that comes from a national expanded access protocol, which was spearheaded by the Mayo Clinic in collaboration with the FDA, and which we participated in at Stanford. So this expanded access protocol was an uncontrolled study of convalescent plasma transfusion to COVID-19 inpatients. Thousands of hospitals across the United States participated, and over 73,000 patients were transfused according to this protocol. The objectives of this study, the primary objective was to make COVID convalescent plasma available. The secondary objective was to assess safety. There was no pre-specified analysis for efficacy, but there's been some post hoc analysis of efficacy, which has been referred to by the Mayo Clinic investigators as a so-called pseudo-randomization approach by antibody titer. And so the kind of rationale for this analysis is that prospectively, there was no requirement for CCP antibody titers to be determined. And so by and large, convalescent plasma was transfused without knowledge of the antibody titer at the time of transfusion on behalf of the physicians or the patients who are receiving the convalescent plasma. An assumption which is made, which may or may not be true, is that patients randomly received convalescent plasma units with different titers. And so given that we think that, if anything, it would be the antibodies present in the convalescent plasma that are mediating the therapeutic effect, if we see a dose-response relationship between the antibody titer and mortality, this could provide some evidence of efficacy, sort of a pseudo-randomized study embedded within this expanded access protocol. And so some of this data has been published or posted as a preprint on medRxiv. This is a study published by Joyner et al. From the Mayo Clinic. And then some of the data comes from an FDA memo, and I'm going to focus on the data that comes from the FDA memo. This data is data that was developed in collaboration between FDA investigators and the Mayo Clinic. And this has not been posted as a preprint or published anywhere that I can see. It's only available in this FDA memo. So for this data analysis, they looked at 7-day mortality of convalescent plasma recipients from the expanded access protocol. And they looked at patients who received either high or low titer convalescent plasma. When they looked at the overall cohort, there was no difference in mortality between those who received high versus low titer units. They did an unplanned subgroup post hoc analysis. And so they did divide this data in various different ways. And that's one of the critiques of this type of analysis is that, they kind of, you could probably cut the data many different ways and come up with many different results. But this one subgroup that is published or that is put forth in this FDA memo is patients less than 80 years of age who were not intubated at the time of transfusion and who were transfused less than or equal to 72 hours after COVID-19 diagnosis. Here, there was a statistically significant difference in 7-day mortality with a mortality rate of 6.3% for those who received high titer units compared with 11.3% for the low titer units. There is other evidence which supports potential efficacy for CCP. However, I think the really important thing to note is that generally this evidence has been of moderate to low quality, similar to the data that I'm showing here. And importantly, no really high quality studies, so no randomized controlled trial has clearly demonstrated a mortality benefit for convalescent plasma. So what about safety? The Mayo Clinic has put forth 2 different manuscripts looking at adverse events in their cohort of patients transfused on the expanded access protocol. The most recent one reports on adverse events in 20,000 transfused patients. Importantly, the adverse event rate that was published by the Mayo is significantly below the rate that one would expect for transfusion reactions to occur with standard plasma transfusion. And so this has led us locally to be concerned that this adverse event rate may be significantly underreported. In our cohort, which included 30 patients transfused on the expanded access protocol, we saw a much higher rate of adverse events. And the particular concerning adverse event that we saw was transfusion-associated circulatory overload, which we saw in about 13% of our cohort, which is more in line with the rate of TACO that you would expect for a critically ill patient population receiving plasma transfusion. So on the basis of the data that I just showed you, the FDA issued an emergency use authorization for convalescent plasma on Sunday. This allows CCP to be provided for treatment of hospitalized patients with COVID-19 outside of the auspices of a research protocol. But importantly, the FDA stated that CCP remains an investigational therapy. And so how are we interpreting this data and this FDA EUA locally in our transfusion service? We agree with a statement that was included in the EUA by the FDA, which is that CCP should not be considered a new standard of care. I think that, locally, we're not incredibly compelled with the data that I just showed you, that truly supports efficacy of this therapy. I think we still think that it's something promising to consider as a therapy, but that we really don't have enough data at this time to say that this is truly an efficacious and safe therapy. We think that it could be reasonable for physicians who, in collaboration with their patient or patient representative, who really understand the fact that this is not an established therapy and that it does have the potential for harm. If there is interest in providing CCP, we think it's reasonable to provide to carefully selected patients who are interested in pursuing this approach. And we think that use of CCP should be restricted to patients who are most likely to benefit and least likely to be harmed by this therapy. And so that would include patients who are early in their disease course, generally less than 72 hours after COVID-19 diagnosis or after hospitalization. And we would express some caution with the risk of volume overload. We're recommending that CCP be transfused over 4 hours as opposed to a shorter time frame, which would usually be used for fresh frozen plasma. Stanford Blood Center currently has an adequate inventory of high titer CCP, and our goal would be to only provide high titer CCP units for transfusion as long as the inventory for that is sustained. We eagerly await results from convalescent plasma RCTs, and very excitingly, the C3PO multi-center RCT of convalescent plasma in emergency departments recently enrolled its first patient at Stanford, and there are many other RCTs of convalescent plasma ongoing nationally and internationally. Finally, for all CCP-related questions, please feel free to reach out to the transfusion service, who can be reached by this pager here. Thanks.
Great, Dr. Hollenhorst, thank you for that great update. Thank you as well to Dr. Huja and for those updates. And a special thank you for all the panelists who hang out with us every week. They're all available to answer any questions in the background, including any that are popping up regarding convalescent plasma or any updates. So please feel free to ask those questions and we'll try to get those answered for you. So I'd like to go ahead now and introduce our new speakers today. But before we do that, I also want to share with you our speakers upcoming as well. So we have next week a focus on the immunology in COVID-19 with Doctors Tai Wang and Bali Palindran, who's joined us in the past for grand rounds. And they're going to focus more on the immunologic phenomenon that we've been seeing with COVID-19 and hope to help us learn more about that. It's been a really interesting topic throughout this time. The week after that, we'll talk with Dr. Kari Nadeau regarding an update on the vaccine status. So really looking forward to hearing what she has to say about her thoughts on the current status of vaccines. And the week after that, the approach of monoclonal antibodies. The Vice President of Regeneron will be joining us to talk about that. Today, we have two really wonderful speakers. We have Dr. Paul Kuo and Dr. Dhanasekaran, both from the Division of GI, Gastroenterology. Dr. Kuo is currently a professor of medicine and the director of hepatology since 2016. I don't have time to go through all the different awards but I will say I found a lot in his bio that really speak to the level of educator, clinician, and researcher that he is. He's an expert and distinguished professor in the field of hepatitis C therapeutics and has been the principal investigator on multiple international trials, recently authored an American College of Gastroenterology clinical guidelines on liver abnormality and chemistries, and really, really happy to have him joining us today. Along with Dr. Kuo, we have Dr. Dhanasekaran. She actually has joined us relatively recently. She's currently working on her Ph.D. in basic and translational research with Dr. Dean Felsher to understand molecular mechanisms of liver cancer. She did her medical training at our colleague, Dr. Verghese's alma mater at Madras Medical College in India, came to join us, internal medicine residency at University of Florida, did her fellowship at the Mayo Clinic, and then came to Stanford in 2016 to do her transplant hepatology fellowship. So we're really lucky to have her joining us as well today. And both of them will be talking about COVID-19 and the gastroenterology, the GI effects in COVID-19 and liver effects as well. So really looking forward to hearing that. Dr. Kuo, I believe you're going first, so I'll let you put your slides up. Thank you so much for joining us today. I'll stop sharing my slides. Great. Okay, great. And so Dr. Kuo, I'll let you go and put your slides up. And thank you again, both of you, for joining us today.
Okay, thanks so much for the kind invitation to discuss the uh, effects of COVID on the GI tract and the liver. So, as all of us know, SARS-CoV-2 is an RNA virus. It was first identified earlier this year in Wuhan, China. It's very similar to the SARS-CoV-2 or COVID virus that was reported in 2004. And just like back then, where there was significant evidence of abnormal liver tests and GI symptoms, we are seeing the same patterns with COVID-19 disease as well. And SARS gains entry into the body via the ACE2 receptor, which enters the target cell. And the GI tract and the liver are particularly relevant because, as you will see, these ACE2 receptors are expressed throughout the GI tract as well. The initial report from China actually demonstrated low incidence of GI symptoms. The first report in over 1,000 individuals, just 3.8%. But subsequent reports have demonstrated that GI symptoms actually can be quite common. And so, for instance, this report showed about half of individuals had digestive symptoms. They were diagnosed a bit later. GI symptoms included anorexia, diarrhea, vomiting, and it was accompanied by higher rates of abnormal liver tests as well. A GI presentation alone, though, actually turns out to be quite uncommon. The first reported case of COVID-19 disease in the US, interestingly, presented with cough as well as GI symptoms with both positive stool and respiratory COVID PCR testing. And one of the interesting aspects of SARS-CoV-2 virus is that you can detect this fairly readily in the stool. And this was a very recently published meta-analysis that shows that the prevalence of stool PCR was in their hands just under 50%. And therefore, this pattern is quite similar to what was reported with the first SARS-CoV virus. In addition, there are now reports showing that you can find the virus in the epithelial cells. So this was a report here of a 78-year-old male who presented with a GI bleed. They had a viral nucleocapsid protein staining, and they were able to demonstrate this in gastric, duodenal, and rectal biopsies. You can see here on the lower panels here, in addition to showing staining for ACE2 receptor. Again, that's the receptor by which SARS-CoV-2 gains access to the GI tract, as well as the liver and other organs. And here is just to give you an idea of the expression of ACE2 receptors in different organs. And I just show this just to show that colon, gallbladder, you have liver here, you have esophagus. It's all well represented with ACE2 receptors. The lung is shown here. So it's not surprising that we would see GI manifestations. And indeed, a recent paper in Science demonstrated that human small intestinal organoids actually support SARS-CoV-2 replication. And this is, you can see here, in fact, they created a small intestinal organoid here, and you can see here at 24 hours, and subsequently here in white, in the upper right panel, you can see here that SARS-CoV-2 is propagated, and you can see here in the bottom panel that this also occurs both in replicating and non-replicating enterocytes. So we're able to demonstrate a substantial presence of SARS-CoV-2 within the GI tract. Individuals with mild symptoms may have significant clinical relevance because these individuals who present with digestive symptoms alone seem to have a delay in their diagnosis. They also seem to have a longer time to clear their respiratory PCR tests. And in this particular report, with 206 individuals, you can see here about a quarter of individuals presented with digestive symptoms alone, and then another 69 presented with digestive and respiratory symptoms. So this is roughly 2/3 of the cohort with some GI presentation. If you had digestive symptoms alone, you are more likely to have a delay in diagnosis, a longer time to clear your respiratory PCR, and they did some stool PCR testing as well and showed that these stool PCR tests also took a longer time or respiratory PCR took a longer time to clear in those with positive stool PCR. Now, in general, we have a host defense against SARS viruses, and it was well shown with the original SARS-CoV virus that gastric acid inactivates SARS-CoV-1. However, it's been very interesting to see that those who are on proton pump inhibitors, blood group A, and older individuals all seem to be at risk for COVID-19, and all of these populations seem to have increased rates of achlorhydria, and this may be part of the reason that we're seeing these presentations in these populations. This is a very helpful diagram that was recently published in JAMA that showed the estimated diagnostic test variation over time. And you can see here in blue here is the nasopharyngeal swab that we typically obtain with SARS-CoV-2 infection here, excuse me, COVID-19 infection. But in gold here is the stool PCR. And what I'd just like to point out is that you can shed virus in the stool for periods much longer than when you've cleared your nasopharyngeal PCR swab. And this may have some applications, this detection in the stool. So this was a recent paper that comes from Spain, where some very industrious microbiologists managed to measure the SARS-CoV-2 RNA in wastewater, untreated wastewater, in 6 different water treatment facilities in a low prevalence area of COVID-19 disease within Spain. And what they found was, when they measured these at 4 different time points from March, mid-March here to mid-April here, they found SARS-CoV-2 virus titers about 10 to the 5th copies, but very low prevalence of the COVID-19 disease. But over the next 4 weeks, you can see what happened was that they had an outbreak of COVID-19, and this environmental surveillance may be useful. Similar findings were reported with the original SARS-CoV virus, and similar reports around the world are reported with COVID-19 surveillance as well. The GI infection can be quite severe in cases. I show you here a case of an individual presented with acute abdominal pain and diarrhea. You have a very thickened colon here on the coronal and sagittal images, with this colonoscopy here demonstrating here, you can see an acute colitis with these patchy erythema. And you can indeed have even more severe presentations with pneumatosis. Here's some ischemic bowel here with it's very dusky here. This person obviously went to laparotomy, and you can see here some fibrin thrombi and crypt dropout. The mucosal surface is up here. Again, these are uncommon but significant presentations. By the way, endoscopy is safe in the era of COVID. All the endoscopy units have across the world and here at Stanford have opened up with mitigation protocols where we look at low-risk patients, which means no symptoms, no contact. And we also classify individuals as intermediate and high risk based on symptoms or contact with COVID-infected individuals. As long as COVID testing is negative within 72 hours, we proceed. High-risk cases are either canceled or deferred to the OR. And all of the endoscopy units, including our own, have cleaning protocols, pre and post-procedure protocols. We are piloting an app to look at outcomes, and we found no COVID-related complications or acquisition of COVID-19 thus far. And there's a link here to a very helpful video that Yuri Ladabam recorded about our efforts here. The CDC has noted that those who are immune compromised and those who have diabetes are at risk for severe COVID illness. And then others that are maybe at increased risk include immunocompromised state, liver disease. And these are really our GI and liver populations that we're going to focus on. The presentations are related to elevated liver tests, and you can see here it's predominantly AST and ALT. Interestingly, AST is a bit higher. There's also been some reports of GGT elevation. The liver biopsy findings, well, there's not a direct viral cytopathic effect. The data are limited, but you see this nonspecific fatty infiltration here with a few lymphocytes percolating through the sinusoids. And these findings were also reported with the original SARS-CoV-1 infection as well. There is an acute presentation with regard to the liver. Acute COVID-19 could present as an acute hepatitis. This was shown here. And again, note the AST was higher than the ALT, 1200. This person was admitted with dark urine and then a day later developed a fever and the characteristic chest x-ray and made a complete recovery. In general, we're going to hear about the populations with liver disease. These are Renu's efforts, but these are the populations that seem to be at risk, particularly for COVID-19. I'd just like to point out that particularly liver transplantation has been disrupted. And we have seen significant reductions in total waitlist additions and transplant surgeries with increases in waitlist deaths as a result of the COVID pandemic. Most severe, not surprising here, these are regions of transplants, but in the areas that have been hardest hit have seen the most significant reductions. Here we are in California and we've actually been less affected by this. And in fact, year to date, our transplant volume has not really changed from the year prior. And this is just due to the efforts here to try to reduce any reduction in volume thus far. So I'm going to stop here and just summarize and lead on to Renu that GI and hepatic involvement of COVID-19 is quite common. gastrointestinal symptoms can be the sole presentation of COVID-19, and fecal shedding of the virus is often noted. Role of transmission is not yet clear, though people are certainly postulating fecal oral transmission is feasible, if not likely. We see commonly elevated liver tests with higher AST levels. And again, one other effect that is not directly related to COVID-19 is that because of the shelter in place, we are seeing more alcoholic liver disease, alcohol use disorder, and non-alcoholic fatty liver disease in the era of COVID. And these individuals will likely be at risk if they also acquire COVID-19 disease. I'm going to stop here and turn it over to Renu. And again, thanks so much for the opportunity to share our experience.
Great. Thank you. Okay, perfect. And Renu, you're still on mute.
Okay now?
Can hear you now, Renu.
Okay, thank you. So thanks to the Department of Medicine for inviting us to share our experience with studying COVID-19 in the context of liver diseases. As was mentioned earlier, I'm an instructor in the Division of GI. I mostly conduct basic research in liver cancer with Dean Felsher. But during COVID-19, when this pandemic hit us, I began to see more of my patients who were acquiring this, and several questions came up, which led me to some of the research that I'm conducting now. I would like to start with sharing the story of one such patient here. So this was a 65-year-old male with alcohol cirrhosis and hypertension. His alcohol cirrhosis was pretty well controlled. He was doing well, and he went on a vacation. He came back to the Bay Area on March 18th after international travel, was doing well when he arrived. After a few days, he developed symptoms of cough and also diarrhea. He was tested at a local hospital initially for respiratory PCR, including SARS-CoV-2, which was found to be negative in the beginning. He was empirically treated with antibiotics, but unfortunately he continued to deteriorate and symptoms worsened. So he was eventually admitted at Stanford with hypoxia and was confirmed to be COVID-19 positive. Interestingly, or unfortunately rather, multiple family members who all went on this vacation trip with him tested positive, and actually his wife did pass away from COVID-19 at a regional hospital. The patient himself, despite our best efforts, eventually did pass away. He was admitted to the ICU, had multi-organ failure, and deceased on April 15th. It was interesting when I was looking through his chart later to note that when he presented, his liver tests, AST and ALT, were elevated compared to his baseline. And throughout the disease course, they continued to go up. It's perplexing because there are multiple factors here. He did receive hepatotoxic medications like antibiotics. He was hypotensive, requiring vasopressors, and ultimately he did have multi-organ failure. And also there was a question of whether SARS-CoV-2 itself could have an impact on the liver. As you can see, just this one patient and management raises so many questions, which I will pose here. The first question is the risk. Are patients with liver disease are particularly higher risk for mortality with COVID-19? If so, can we predict who among these patients with liver diseases are more at risk? And can we stratify these patients using biomarkers or clinical presentation features to know and to predict who we have to monitor closely? And lastly, of course, and importantly, how do we manage these patients with chronic liver disease and COVID-19? In the beginning, there were hardly any answers for these questions. In the past 6 months, our groups and several other groups have conducted studies which will address these questions. I have framed the presentation in such a way that I will try to answer these questions one at a time. So let's look at the first question. Does pre-existing liver disease increase risk for mortality with COVID-19? As Paul alluded to, the CDC classifies liver diseases as one of the comorbidities which could increase risk for mortality. The best data for this comes from this study, which was published in Nature in July 2020. This is from the NHS database called Open Safely. They have looked at 17.3 million adults with COVID-19, 100,000 with liver diseases. They had a mortality of 11,000, of which 181 had liver disease. As you can see here, they adjusted for multiple demographic and comorbidities to identify independent risk factors which predict mortality. And liver disease was found to be associated with a hazard ratio of 1.75 for mortality compared to patients who do not have liver disease. This data has been shown to hold true in the United States in smaller studies which have matched control groups. So having liver disease does appear to increase risk for mortality. The second vulnerable population we take care of as hepatologists are patients who have undergone a liver transplant. As you know, these patients are chronically immunosuppressed, and there is concern that this could increase risk for mortality. Two large studies, this one from Spain and the second one from Italy, have addressed this question. And they have shown that the risk for mortality between transplant recipients and non-transplant patients are similar once you adjust for age and other comorbidities. This is very reassuring and a welcome news for these patients. So let's move on to the next question, which is, what are the predictors for mortality among patients with chronic liver disease? This was the main question we tried to address in this study that is being conducted with Stanford as the main site. It's a prospective observational multi-center study on COVID-19 in patients with chronic liver diseases, which we called it the COLD study. We were able to recruit investigators from these 15 states and 23 sites across the United States, and all of them have worked very hard to contribute data from 1,025 patients with liver diseases, of which 112 patients are liver transplant recipients. This is one of the largest databases in the United States for patients with CLD and COVID-19. I'll briefly introduce some of the features of this cohort. So the median age was 58. As you know, for the CDC data for the general population, the median age is lower, around 48. The gender distribution was slightly higher in female at 55%. Here I show the racial and ethnic distribution. As has been shown in other cohorts, African American and Hispanic ethnicity were disproportionately higher in these cohorts compared to their distribution in the general population. As far as etiology of chronic liver disease is concerned, the most common underlying chronic liver disease was non-alcoholic fatty liver disease, which is not surprising given that it is the most common cause of CLD in the United States. This was followed by hepatitis C and alcohol. It's interesting to note that only 26% of these patients actually had cirrhosis or end-stage liver disease. Majority of the patients did have mild liver disease when they contracted COVID-19. To broadly look at the outcomes in this cohort, hospitalization rate was 61%, 23% in the ICU. Overall mortality was 14%, with most of the mortality being related to COVID-19 and not due to liver disease or liver failure. And again, in the liver transplant population, the hospitalization rate was 72% and the overall mortality was 22%. But I've shown you in the previous studies, once you control for age and comorbidities, this appears to be similar. These patients generally tend to be older and have almost a 50% incidence of diabetes and hypertension and metabolic syndrome. I would like to, again, link back with what Paul had mentioned about GI symptoms. We collected detailed information on presenting symptoms, and GI symptoms of diarrhea, nausea, vomiting were present in approximately 25% of the patients. And interestingly, if patients presented with GI symptoms, they were more likely to have more severe COVID-19. So this is a good clinical data that we can use. When we have patients with liver disease who present with a lot of diarrhea, we need to monitor them more closely. This was the main question of this study. What are the predictors of mortality? We performed multivariate model analysis. We adjusted for various demographic and comorbid risk factors and identified these that are listed to your right as the main independent and significant predictors of overall mortality, and the x-axis is showing the odds ratio for mortality. As you can see, There you can see some of the more common, well-identified factors, including older age, hypertension, diabetes, and COPD. I would like to bring your attention to the liver-specific factors here. One is HCC, or hepatocellular carcinoma. Second was alcohol liver disease. And third was decompensated cirrhosis. I'll go into some detail on this. So patients who had decompensated cirrhosis appear to bear the brunt of the adverse outcomes with this disease. So these are patients who have cirrhosis, but also have a history of either ascites or hepatic encephalopathy or variceal bleeding or other decompensating events in their past. The hospitalization rate in those patients with decompensated cirrhosis was 80%, and the mortality was very high at 40%. The patients who were non-cirrhotic appear to do relatively well, as also shown in this survival curve here. Why is this important? These are the sickest patients among those with chronic liver disease. They have high level of contact with the healthcare system. So we need to have in place mitigation effects to make sure we are protecting this highly vulnerable subgroup among those with liver disease. The next and interesting association we found was with alcohol-related liver disease. Patients who specifically had alcohol-related liver disease had significantly worse 30-day survival in this cohort. And also we collected data on ongoing alcohol use during the pandemic, and 33% of patients with chronic liver disease reported alcohol use. And even more alarming was the fact that 50% of patients with alcohol liver disease reported ongoing alcohol use during the pandemic. And why is this important? Because several reports have now been published showing increased alcohol use during COVID-19 pandemic. There are multiple speculative reasons for this, including increased depression and anxiety, ease of access and lack of diversion during shelter in place, access to care, especially psychiatric care, has been limited. And some of the medications like steroids we use to treat, high-dose steroids we use to treat alcohol hepatitis might have increased their risk to acquire COVID-19. And I cannot minimize the impact of the economy or job loss or stress and isolation that's having on patients who already have alcohol use disorder. Recently, a federal committee has recommended that men should limit their alcohol use to 1 drink a day amid new concerns of rising alcohol use during the pandemic. As you all know, the general recommendation has been 2 drinks a day. So this is a cut in 50%. This is coming on the heels of a 20-year rise in Americans drinking, but also they specifically looked at the increased alcohol use during the pandemic. So I'll just switch gears and quickly talk about liver injury in patients with chronic liver disease and COVID-19. As Paul has mentioned, liver injury is common, especially in patients with chronic liver disease. Around 45% of patients had liver injury, and 17% of that was severe. It was mostly in a hepatocellular pattern. The liver enzymes ALT, AST, and alkaline phosphatase are shown here compared to baseline at diagnosis and at peak. You can see that at peak, AST goes up the highest, and so does ALT. Alkaline phosphatase goes up to a lesser degree. Even more important to note that those patients who had severe liver injury had higher risk for mortality compared to those who did not. So this can be used as a biomarker to predict who will have risk for mortality. We also did a detailed drive-through on which patients are at risk for liver injury. And we found that if they had metabolic syndrome, they were on vasopressors or antibiotics, they had higher risk for liver injury. This highlights the fact that this is likely a multifactorial process and need not necessarily be due to cytopathic effects of the virus itself. But there is some good news. We had a small cohort of patients who had recovered, had resolution of COVID-19 symptoms, and they showed that their liver enzymes appear to mostly come back to normal after resolution of symptoms, which is good. We are conducting longer-term studies to confirm this. So I would like to circle back to the patient and the questions that had been raised and end with some of the major take-home points. So for the first, some of the important answers here are, yes, chronic liver disease, especially cirrhosis, and particularly decompensated cirrhosis, are at increased risk for mortality with COVID-19. Alcohol liver disease and ongoing alcohol use appears to worsen COVID-19 mortality. And these patients should be monitor closely, and mitigation efforts should be ongoing. And we offer telemedicine and other multiple mitigation efforts here at Stanford. Second important point is liver injury is common with this viral disease. Up to 30 to 40% of patients can have elevation in liver tests. This is usually multifactorial, but it is important to monitor closely because you can use liver tests as predictors of mortality and use this to stratify patients. So I would like to take a minute here to point out that several faculty in our division have been working very hard over the past few months and have published several high-profile papers describing the impact of COVID-19 on liver and GI diseases. I've just listed them here. I'm happy to share the list. But this has helped us answer several of the questions that have come up. So with that, I would like to again thank you for the opportunity to discuss, and I'm happy to take questions. Thank you.
Great, Dr. Dhanasekaran and Dr. Kho, thank you so much for those presentations. I have a couple questions coming in here to both of you. Dr. Licky asks, if achlorhydria is a risk factor, why do you think there have been suggestions that peptide use may be protected? Has this been looked into further? I wanted to ask that question as well. The reports earlier about famotidine potentially being therapeutic. Any thoughts you have on that?
Sure. So for H2 receptor blockers do not suppress acid nearly to the degree that proton pump inhibitors do. PPIs really shut down the proton pump and make you achlorhydric. H2 receptor antagonists such as famotidine certainly reduce pH, but very, very modestly. And again, I don't know the data of SARS-CoV-2, but with the original paper where they looked at this with the original COVID virus, the pH reduction that was roughly in the range where famotidine would put the pH would not seem to be rendering them at higher risk. That is, the amount of acid suppression may not be as sufficient. I also did briefly look at the famotidine report as well, because I found it, just like you, very interesting. And so what I would say is it's early. These are all associations. We're going to have to tease these out.
Gotcha. Great. Another question here that came up a little earlier, Dr. Kho, when you were speaking, and thanks, Ben, for also putting some comment in here. Someone asked, can you test positive for COVID in the stool, but negative in the nares as noted in the lungs? So yeah, can you
yes. So yes, although you generally wind up, if you follow them, you may test first. I think the scenario is you would test in the stool and subsequently test positive, I think in the nasal mucosa, because I think most people are now being diagnosed clinically through their respiratory symptoms. But yes, you're absolutely right. We'll have to see later if this stool shedding, that this may be the reservoir of individuals, and we don't routinely do stool PCR. So the question is, could you shed stool without ever having a respiratory PCR be positive? I think the answer is, my guess is you could.
Great. Another question that was asked a little earlier, is that virus in the stool fragments, or is it actual culturable virus? Dr. Pinsky mentioned, as we all, I think it's been cultured in the stool, but typically is it actual active live virus? So
there are now early reports that people have said that this indeed, what they can recover is infectious. There have just been one or two brief reports on this that have been published recently, Errol. And what I would say is the jury's still out. Certainly there are other coronaviruses that are infectious, and fecal oral transmission is not uncommon in the coronavirus family. So the jury's still out on this. But I tend to think that there will be a component here of fecal oral transmission. It's not yet definitive.
Okay, gotcha. Dr. Berry recently gave a really great talk on the gendered lens in COVID-19. She's asking here, is there a gender difference between GI presentation in COVID-19 or ACE expression in the GI tract? Has this been looked at?
If it's looked at, it is unknown by me, Errol. Great question. I do not, unfortunately, know the answer to that. And Renu, I didn't see a split in your data with regard to gender.
Yeah, in the liver disease, patients with liver diseases, gender did not impact either outcomes or symptoms. They didn't seem to change. They were not different.
Gotcha. Still something that needs to be looked at closer, it sounds like, potentially. So this question was asked, I think Dr. Crow, you may have somewhat commented on any other thoughts or recommendations for patients on PPIs currently?
Well, we try to, well, if you need a PPI, you need a PPI. We are all guilty, Earl, of putting somebody on a PPI just in clinic and just remembering not to take them off. For instance, I will tell you, we now know that proton pump inhibitors are not real, they're associated with worse outcomes in cirrhosis. And so we very carefully try and get these individuals off of their proton pump inhibitors when we see them in our liver clinic. And I would just urge that if you really need it, you really need it. But if you don't, this is yet just another reminder that we should be evaluating our medicines in clinic carefully.
Gotcha. Okay, great. We have one more question here coming up from Dr. Siegel, Robert Siegel. Is it possible to determine the extent to which GI and hepatic complications are due to GI infection and which are due to secondary pharmacological phenomena, physical treatment, stress of severe systemic illness, immunodysregulation? Basically, what's from COVID and what's from
right. So in other words, are the GI tract and liver innocent bystanders, or are there true invasive diseases? So let's start with the liver. I think in general, the liver is an innocent bystander, and it's the cytokine response that is causing most of the elevated liver tests. And again, it reflects the severity of the overall response. In the GI tract, on the other hand, there may be direct disease caused by the SARS-CoV-2 virus. It's still early, but in my opinion, I think that certainly some of the nonspecific GI symptoms, anorexia, can be seen with any viral syndrome and the immune response. But I think in certain individuals, there's no question, particularly these severe presentations. So I do think that the GI tract can be a bit more prone to a truly cytopathic SARS-CoV-2. Again, much more to be determined and researched in this area.
Great, excellent.
Yes. Add to that, so it's a good question, because all these patients, like the patient I showed, do get other medications. They have other systemic complications. So how do you tease that out? We did try to collect a detailed list of hepatotoxic medications and whether they had hypotension, other known causes of abnormal liver tests. And I was not surprised to see that almost 90% of them did have another clearly more direct insult, which can explain the liver test abnormalities. But it is also unique that patients who have influenza and pneumonia, even when they are in the ICU or very sick, you do not see this extent of liver test abnormalities. So like Paul mentioned, it could be the difference in the cytokine storm and the immune response. But yeah, it looks to be multifactorial.
Yep. Great. I got Dr. Regis here on audio. He has a comment and perhaps a question to ask. Dr. Regis?
Yes, thank you both for an extraordinary presentation. Very, very helpful. I just read a recent report of an outbreak in an unused apartment building in China, where several individuals on the top floor who moved back in were infected, and they were able to find COVID in the sewer system, and it had probably aerosolized, very reminiscent of the outbreak in the infamous apartment building in Hong Kong during the SARS epidemic. And I wonder if you have comments from a public health point of view about, the virus in sewage and infectivity. Thank you.
Yes, thank you so much. I think this is a fascinating area of research, and I think that we are going to need to pay much more attention to our wastewater. And there have been also limited reports that when they look at areas that have high areas of COVID infectivity, obviously areas where people remove or don PPE was one area. Interesting, toilets were another area where there was a high level of virus recovered. And so I think, as you say, to have people go back into areas where there have been lots of high-risk individuals it's, in my opinion, we're going to have to survey, but clearly cleaning, terminal cleans are going to be required, I think, in certain areas. And as you said, surveying the water, I think, may turn out to be a very useful environmental surveillance tool to allow us to mitigate or reduce the likelihood of outbreaks in the future.
Great. I have a few questions coming up here. One comment, great talks. Any thoughts on mechanism why patients with alcoholic cirrhosis fare worse than other forms of cirrhosis?
Renu, do you want to take that?
Yes, I've been thinking a lot about this, and we have some hypothetical possibilities. So patients who have alcohol liver disease do have this, there is a connection to the gut microbiome liver axis, and it has been shown that they have a hyperactive innate immune system and inflammatory cytokine response within the liver, which drives the alcohol cirrhosis. And there's been more recent data that there is this cirrhosis-associated immune dysfunction, they call it CAID, that's associated more specifically with alcohol liver disease and the inflammation in this context. So hypothetically, you can see that a cytokine storm that's happening during COVID-19 could worsen the already existing inflammatory microenvironment within the liver. We don't have specifically direct data to show this. We've been trying to prospectively collect blood samples and understand the immune mechanisms, if any. In terms of just clinical presentation though, patients with alcohol liver disease tended to belong to that more decompensated cirrhosis subgroup. For example, those with non-alcoholic fatty liver disease were predominantly having either hepatic steatosis alone or inflammation without having a lot of fibrosis and decompensation. So their physiologic reserve is already depleted. And on top of that, when they get a very severe systemic illness, it likely complicates it. We try to adjust for these physiologic factors to see if alcohol liver disease still stands out as to the extent that we can. But I still think these patients are likely sicker to begin with.
Great, thank you. Next question here. Were the bowel injuries shown in photo and slide correlated with small vessel thrombi?
Yes, they were. In fact, I tried to show that in the top right photo micrograph in there. That's correct. Good pickup.
Great, thank you. A few of them popping up, so we'll just try to get through them all. We had a case of Lovenox-induced hepatitis in a non-COVID patient. Any association with abnormal LFTs and the use of Lovenox in COVID, given that we use it a lot in COVID patients for prophylaxis?
Oh, sounds like an idiosyncratic drug reaction. I consider that bad luck, and that wouldn't deter me from using Lovenox again. It's much like getting an anaphylactic reaction if you give vitamin K, right? It's rare, but it's just not pleasant. So I think you would be okay there, and that would not deter me from using it further.
Gotcha. Great. How many with alcohol liver disease may have been on naltrexone, and do we know the safety of the use of naltrexone with COVID?
Yeah, it's a good question. We did not, at least in the cohort that we had, we did not collect data on how many were on naltrexone. But given that it's generally safe and we do use it with close monitoring in our patients with cirrhosis, I would think with this problem of increased alcohol use and alcohol use disorder management, I would prioritize it and just monitor the patients closely.
Got it. Is there, interesting question, is there synergy between SARS-CoV-2 and other hepatotrophic viruses, hepatitis B, C, CMV, et cetera?
Not that I am aware of. That doesn't mean it doesn't exist. But I don't believe there are any synergies here that would lead to more severe clinical outcomes, Errol.
Yeah, we did try to see whether those patients who have active hepatitis B and hepatitis C, whether they had a flare or worsening of their liver disease during COVID-19. At least in our cohort, we had around 300 plus patients with viral hepatitis B or C, and we didn't see that happen. The viral hepatitis appeared to remain stable. That's useful.
Great. Hector asks, is there any connection between the SNP-IL-28B polymorphisms and liver test abnormalities?
So IL-28B is a marker of innate immune response, and that's a great question. With other viruses, you can actually predict the response. the answer is I don't know of any reported association yet with COVID-19.
Okay, thank you very much. I just want to comment one question here before that. There's a couple questions coming out about CDC recommendation stop testing. Julie, I'll try to get an answer that out to you when we send out the follow-up email for you. Another question has popped up here. With worse outcomes in obese patients, do they stratify one risk according to the presence of non-alcoholic fatty liver disease?
Yeah, so that's been an important area of study, and I was surprised when NAFLD didn't come out as the biggest risk factor, because patients with non-alcoholic fatty liver disease have higher prevalence of obesity, diabetes, hypertension, and all these components of metabolic syndrome. But I think in our cohort, they, like I mentioned earlier, tended to have less severe cirrhosis. So the right control would be patients who are matched for cirrhosis stage, and then NAFLD versus no NAFLD. So we are analyzing that data now. And I can tell you, based on our preliminary analysis, those patients who have fatty liver disease and diabetes, that combination appears to have higher mortality. As we all know, diabetes appears to be an independent driver of mortality in these patients. So when you have both fatty liver and diabetes, we saw that association. The obesity association, at least in this cohort, so far I have not seen it. There could be multiple reasons, but diabetes seems to be a stronger predictor.
Great. Excellent. I wanted to end on this question. I see Nira also put a comment. Thank you. Dr. Gothiner asked, I believe there's a recommendation to lower the toilet lid before flushing after a bowel movement. I always wondered that question. Dr. Huja mentioned can't hurt. I agree with that. Curious what your thoughts are.
Yes, there is that recommendation, and so that, and again, it is related to the studies that I have referenced, that they have found that infectious COVID-19 on the toilet is very high and not too different from areas where PPE is donned and doffed.
Okay, gotcha. I see a couple other questions have been popping up here. Dr. Ahmed asks, I think the socioeconomic status of alcohol liver disease places this subgroup at higher risk. I think he was just putting a comment in there. Any other additional comments to that, Dr. Kuo or Dr. Dhanasekaran?
I think Dr. Ahmed and his team have also published some very important early work and some ongoing work on COVID-19. And I completely agree that we would have to look into the socioeconomic status and also the risk for acquiring COVID-19 more closely. There's some ongoing work, but I have a feeling we'll find that connection. I agree with him.
Great. Dr. Ron Lee asked, among the patients with severe COVID and GI symptoms, did all of them have pulmonary and systemic complications? Should we assess a patient positive for COVID with GI symptoms but no other symptoms? Good question.
So the answer is there were some that had a GI presentation only, but that's actually going to be quite uncommon, and that ultimately you are able to find the PCR, you can find the virus elsewhere, though I suspect the problem is many of these people with GI symptoms may not ever get diagnosed. They may have a GI presentation alone. And so we're going to need to have a higher degree of awareness in people coming in with nonspecific GI symptoms who are otherwise healthy, and that these individuals may actually, this may be form fruste, if you will, of COVID presentation. Again, we don't know the denominator. I think that's the issue here. And we don't routinely do stool PCR testing as well. So this all remains to be teased out at this point. Excellent question.
Great, thank you. Another question, another comment question by Dr. Croak. Alcohol abuse kills 3 million a year globally, most of them men, from the WHO. More than 3 million people died in 2016 due to drinking too much alcohol, meaning 1 in 20 deaths worldwide was linked to harmful drinking, according to the World Health Organization said Friday. Are there any efforts to keep social connectivity for recovering alcoholics ongoing during the COVID era?
Oh, yeah, I mean, there are efforts, but you know, so many people's support systems have just collapsed during the COVID-19 epidemic. I know many people are presenting. We've had the presentation here at our own center as well as across the country, young people coming in with severe acute alcoholic hepatitis. And you know, here we have an exception pathway in our transplant program for young individuals who are presenting with alcohol use disorder and end-stage and acute liver failure. And centers are a bit more forgiving now. I think that's the trend now, because many of these support systems have declined. Yes, there need to be more efforts. I don't know of any national efforts to actually address this very important topic, though.
Gotcha. Dr. Gibbs asks, among pregnant women with COVID-19, we have noted a clustering of cases with intrahepatic cholestasis. Any thoughts on the mechanism? And he also notes great presentation.
Yeah, that's very interesting. I would be very interested in looking at their pattern. Like Paul mentioned, the initial thought was that ACE2 expression was predominantly on cholangiocytes. And there are some patients who we see massive elevation in GGT. The predominant pattern appears to be hepatocellular, but you do have a subset that appears to have a cholestatic pattern. We know that the intrahepatic cholestasis of pregnancy is a very specific condition. So I wonder if there's some synergy there, that there's ongoing cholestasis and somehow acquiring COVID-19 makes it worse. I don't have any other, direct data to support the hypothesis that it's a cholestatic.
The only thing I can think of is that the hormone perturbations in pregnancy may actually change the susceptibility of some of the canalicular enzymes. But this, I just want to say, I want to stress the word speculation, Errol.
Gotcha. Gotcha.
If they have a cluster, it's something that we should,
Yeah, great. Yeah, we didn't know that. I didn't know that.
Excellent. Well, we just hit 9:01 and it looks like we cleared all the questions. So perfect timing. I'm going to end it there before any other questions pop up. But if there are any follow-up questions, please email us. I'm happy to connect you with Dr. Dhanasekaran and Dr. Kuo. Thank you so much for a wonderful presentation. That was really enlightening and helpful. Thank you to all the attendees for joining us today and for asking a lot of great questions. And thank you to the panelists for answering many of the questions in the background and joining us every week. We hope everybody's staying safe. Please let us know if there's anything else we can do from a communication standpoint to support you. And I hope everybody has a great week and stays safe. Thank you, everybody. Bye-bye.
Thank you for the kind invitation. Bye-bye.
Bye.
Bye.